Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Happy New Year. Today is January 10, 2023. And as you can see, we have two guests with us. As always, this will be your chance to get your COVID questions answered. But also today, we're going to be talking a little bit more about emergency preparedness and infectious disease response, actually with a focus on Ebola. Because while there has been the COVID work continuing, behind the scenes, we have been working very hard on monitoring and making sure we have systems in place because there has been an Ebola outbreak going on in Uganda. And so you're going to hear some more about this, but we're happy because different than COVID, which is continuing, this Ebola outbreak in Uganda, we are anticipating that probably tomorrow the Uganda Ministry of Health is likely to declare this outbreak over. And if they declare it over tomorrow, then the WHO, the CDC would follow. That actually does impact work that we do here in Chicago. And so we'd gotten some questions about it, and just given the really good news and some of the difference with COVID, wanted to invite a couple of guests on. So I'll let them introduce themselves, and then just to remind you, we will take a look at COVID data. Then we're going to go through some slides about Ebola and our work here. And then in the last part of our time together, you'll have the chance to get your questions answered directly. You put them directly into the box below, use the hashtag AskDrArwady on either Facebook or Twitter, and we'll take your questions at the end. But to get us started, so let's introduce our guests. Both of these folks have been on this show before because both of them are real leaders at the Chicago Department of Public Health. So first I'll introduce, this is Dr. Stephanie Black. She is one of our medical directors, an infectious disease physician. And then this is Mr. Christopher Shields. He's our assistant commissioner for emergency preparedness and response. So I want to just have you both, so folks have a sense of who you are. Tell folks a little bit about you and your team, maybe what you've been doing with COVID, how long you've been with the department. Just give folks a little bit of background. So Dr. Black, we'll start with you.
Good morning, everybody. Thank you for having me on today. Happy to be here. So as you said, I'm an infectious disease doc by training, and I think I have the best job in the city. I work with fantastic teams, and we primarily are doing outbreak investigation and response in various settings. So in the community, in our communicable disease program, and then in healthcare settings in that group. And we are working on infection prevention and control, education, and outreach. So
great.
Thanks.
Very busy team. The questions that you're always asking me about, whether it's a foodborne outbreak, whether it's monkeypox, whether it's COVID, emerging diseases, botulism, whatever it is, her team and folks around it are the ones really driving a lot of that. So
and lots of the long-term care facility kind of post-acute care settings with COVID response.
Exactly.
Yeah.
Perfect.
Thanks.
All right. And Chris Shields.
Yeah, good morning. My name is Christopher Shields, and my team is responsible for a lot of the things that happen behind the scenes. The plan development, the policy and procedure development, forecasting the potentiality of a disease transmission or how far the disease will go. Do we have the infrastructure in place? Do we need to acquire an infrastructure asset, whether it's a piece of material, a piece of technology? And then we run all that up through scenario development and then training and exercise. So my team kind of builds the foundation components of what preparedness in multiple theaters could look like, and then we train and exercise against it. And not to say that Dr. Black's team is not phenomenal. My team is also phenomenal as well.
Yeah, absolutely. And so, where we're thinking about things like PPE and moving large amounts of materials and a lot of the exercising that we had done, thankfully, before COVID got here, which put us in a pretty good place compared to a lot of the rest of the country. That was really Christopher's team driving a lot of that. And so these two teams represent a lot of folks at the department and a lot of folks that you might not think that much about because they're not the people who you go to your doctor to get medical care. They're the folks who behind the scenes are protecting the population population's health. So thank you both for being on. And again, you can put questions in for them or for me. We're now going to go ahead and turn to a quick COVID update and then some real slides and presentation about Ebola and what's been happening, and looking forward to a good conversation. So first of all, as always, you can go to chai.gov/COVID-. We continue to update this right now, still every workday, Monday through Friday. And you can see on the COVID summary that overall, we are doing okay from a COVID perspective. You can see our cases continue to be in the 350 a day or so, relatively stable. We have around 30, right here, 29 Chicagoans newly being admitted to the hospital with COVID-19 every single day. So sometimes when people say, is COVID over? I say, not well, we have 30 people getting admitted every single day with a COVID diagnosis. But still, nothing like the huge surge that we saw last winter, and I'm pleased about that. We are continuing to see deaths. I want to note that since the last time we had Facebook, we have passed the 8,000 mark. So we have now had 8,003 Chicago residents die from COVID, and COVID remains the number 3 cause of death behind heart disease and cancer. So also very much not over from that respect, but doing so much better than we were before we had vaccines, before we had treatments. We are also, I want to make the point, doing around 1,800 COVID vaccinations every day here in Chicago. So that's not nothing. I want to encourage anybody who's not up to date with their vaccines to do that. And there's a lot of work happening and still a lot of people getting vaccines, which is good. Around 2.3% of all of our emergency room visits are due to COVID right now. And right around 5% of our hospital beds, 1 in 20 across the system, is taken up with a COVID patient. So I'm going to turn to presentation here. And first, I wanted to highlight that my two guests here today were both of the department's what are called the Kathy Osterman Award winners. So every year, the city of Chicago recognizes outstanding longer-term city employees who really go above and beyond. It's a big deal. There's only about 12 winners across the entire city of Chicago, and we had 2, and it was Dr. Black winning in the Outstanding Mentor category, and then Mr. Shields winning in the Outstanding COVID Recovery. So this is from a luncheon with the mayor that happened in December, and so, you know, I only bring the best of the best when we do COVID, and congrats to both of them. All right, so quickly on COVID, the basic messaging has not changed. The things you can do to stay safe from COVID in the new year: vax up, first and most important, mask up, back up, open up, wash up, and test up. We are still at a medium COVID level. We're at a medium COVID level because our hospitalizations are over the threshold of higher concern, but I'm happy that we're still at medium. I was concerned that with all of the holiday gathering, we would have hit high by now, and I'm pleased that we haven't, and thank you. I've seen a lot of people putting on masks on the subway. I know a lot of people were doing a lot of testing ahead of the holidays, not having COVID top of mind, but helping us keep it from getting out of control. If and when we get to a high COVID level, which I would be the happiest person alive if we got all the way through this winter without ever getting to high. I do think it's likely we'll get there, probably because of variants, and I'll talk about that in a second. But just as a reminder, if we reached a high COVID community level, we would issue a formal mask advisory. But you don't have to wait for advisories to put masks on. Last week, 20% of U.S. counties reported a high COVID community level in orange. You can see the Northeast around New York has a lot of orange right now, but also so does kind of West Chicago in that Springfield, Quincy area. So if you're, not Chicago, excuse me, Illinois. So if you're traveling down to that portion of Illinois, you should be putting a mask on in that setting. There's a lot of transmission. Their hospitals are getting more stretched. And 42% of counties in yellow reported a medium level, which again is where Chicago and Cook County are. So we've been getting a lot of questions about variants, and I want to just tell you where we are on this. There's this variant that is every variant we are seeing right now, every subvariant is Omicron. That's the most important thing to hear. I would be the most worried if we had a new variant of concern, meaning a new letter of the Greek alphabet. If we were talking, instead of Omicron, we were talking about, Pi or Sigma or Tau or a new variant of concern, that would be my biggest worry. We don't have that. But we are still seeing the emergence of more infectious Omicron subvariants. And this XBB 1.5 you might be hearing about in the news, it is the most contagious version of COVID yet. And so here in the Midwest and in Chicago, we are seeing it. It's in this dark purple. You can see up at the top here, it's still only about 7% of our cases here. And most of what we're seeing are these other Omicron subvariants. But across the U.S., that same dark purple you see in the Northeast, most of the cases now are this XBB 1.5. Again, the most contagious variant we've seen yet. And given prior experience, I expect that this will probably outcompete and probably be getting into the Midwest and into Chicago over the next few weeks. We probably will see some increase in cases. I talked about this quite a bit the last week that the last Facebook Live that I was on. So if you want to go back and hear more about the genetics, you can, but basically XBB, it's just a recombination of two different Omicron subvariants, BA2. So it's all still on the Omicron chain, but it doesn't look like it's making people notably sicker, but it is more contagious, and people who are not up to date with their Omicron vaccine are at higher risk. And so just as a reminder, since the Omicron variant became dominant, unvaccinated Chicagoans almost 3 times as likely to be hospitalized than those who are up to date. So if you got your original vaccines, that's wonderful. But if you haven't had a COVID vaccine since Labor Day, you are not up to date. You don't have the best protection against Omicron, and you should come up to date. We are continuing to offer our Protect Chicago at Home program. So no matter who you are, no matter where you live in the city, weekends, weekdays, mornings, afternoons, evenings, we will bring COVID vaccine to your home. As long as somebody is getting a COVID vaccine, we will also bring flu vaccine to your home. We'll do up to 10 people. Give us a call or sign up at home. Would love to see people continue to take advantage of that. Also, just a reminder, if you've not ordered your most recent round of free at-home COVID tests, you can go to covidtest.gov. You don't have to put in anything. There's no insurance information. It's entirely free from the federal government. They will ship tests to your home. You can also call that number if you don't have internet. And we were getting a number of questions, so I wanted to just take a second to highlight about what do I do about at-home COVID tests expiring. So let's just talk about this. The FDA authorizes all at-home COVID tests, just like they do all other tests, all other medications. There's a lot of paperwork that goes into authorizing a test, showing that it does what it's supposed to do. They give it an expiration date at that time, but then especially if it's a newer product, they perhaps haven't been able to monitor these new tests for a year or 2 years to know how long the shelf life is. So as stability testing data comes in, where you know that the test is just as good as it was a year ago, the FDA will often extend expiration dates. And so all tests, of course, have a shelf life, just like all medications have a shelf life. So if yours has been sitting in your medicine cabinet for some time, you do want to make sure it's still accurate and that it's working. And so generally they are labeled for between 12 and 20 months, but there are a good number that have had their expiration date extended by the FDA. So if you look on the back of the test here, up on the right, you'll see the second one here is your expiration date. So like this one here had an expiration date of October 16, 2022. But if the FDA doesn't recommend using a test that expired, but you can see if it's been, if the expiration date has been extended. There's a link down here. Also, if you just search it on Google, you'll literally pull up the test and you can look to see, is the expiration date extended? This is what the actual website looks like. It has pictures of your test, and you can click and have confidence that that there's a good chance your test may have had a longer expiration date. So thanks to the folks with questions about that. Finally, I just wanted to remind you that we want you to take action if you test positive for COVID-19. That has not changed. That I do not expect that to change. After a positive COVID test, day 1 to 5, you need to stay home, regardless of vaccination status. Also, if you're at high risk for severe illness, we want you talking to your doctor about treatment. Day 6 and on, if you're feeling better, you can be out and about, but days 6 through 10, you must wear a mask. COVID treatments are available. This is where we're saying, think about Vax, but also Pax. Pax being short for Paxlovid. If you're testing positive at high risk, there are test to treat locations, pharmacies that can do a test on the spot, look at your medications, prescribe you that Paxlovid, or get it through your doctor. But because you've got to get treated in the first few days of symptoms for these treatments to be effective. And then finally, we've continued to get a number of questions about ventilation and making the air safer. So I wanted to highlight that there are many ways to make your air safer during COVID, especially if you're having a gathering. So anything that reduces the level of infectious particles in the air help. There's some low-tech things to do. The easiest is just to crack open a window. Bringing fresh air into your home helps, even if it's a few minutes every hour during the winter here. Turning on exhaust fans, even in your kitchen and in your bathroom. If you have visitors, just pop those on. Leave them on for an hour after they leave. They're an easy way that you already have to increase airflow in your home. And then think about using a fan. We don't usually think about turning on a fan in the winter, but again, those help circulate, reduce the level of infectious particles. So you turn on your fan if you have a visitor, and again for an hour after they leave. And then if you want to have some more significant investment in your home, consider an air filtration system. You can get these portable HEPA air cleaners. You plug them in and they help circulate air, pull infectious particles out of the air. It's sort of a do-it-yourself portable air cleaner. And then you can also, if you have air conditioning at your home, you can do some additional filtering there. Turn your HVAC fan to on if you have visitors there. So not auto, but on. So you're not turning on the air conditioning, but you're turning on the fan. And then there are higher efficiency pleated filters. Those should be changed every 3 months. There's a good chance you may want to do that if you're getting your heating or air conditioning serviced. And then there's links here for additional resources from CDC, EPA, and CDPH. But I encourage you, all of these things help keep the risk of infectious diseases, not just COVID, down in your home. We are continuing our partnership with City Colleges of Chicago, where we have free vaccines for everybody. This Saturday, we will be at Richard J. Daley College, 9 a.m. to 2 p.m. We've got all the COVID vaccines. We've got all the flu vaccines, everybody age 6 months and up. Register, please, but walk-ins are also welcome. So as always, if you have COVID questions, you need a vaccine or a booster, go to our website, or we are still 7 days a week staffing our COVID hotline in Chicago, 312-746-4835. We've got great folks on the other end of that line who will help figure out whatever your COVID needs are. And with that, we're going to turn to a conversation about Ebola preparedness. And if you missed the beginning, I've got two guests on today because I want you to understand some of what goes on behind the scenes. There's been this Ebola outbreak in Uganda that we've been doing a lot for here in Chicago. We're anticipating that it will be declared over tomorrow. COVID's not over, but a lot of other outbreaks we are able to conclude, and I want to highlight that. So let's start. I'm going to start with Dr. Stephanie Black, again, infectious disease doctor at CDPH. Can you just remind folks, very high level, what is Ebola virus disease?
Sure. So Ebola virus disease, there are several different types of it, but they all generally follow this pattern of symptoms. So infection occurs when you have to be exposed. So you'll hear about these symptoms. These symptoms are common to many other diseases, but in order to have Ebola, you have to have an exposure to somebody who's had it. So that means being in contact with somebody who has had Ebola, somebody maybe who's sick or had an unknown virus. These are the questions we ask people who have traveled in areas where there are outbreaks. If they've attended a funeral, if they're a healthcare worker, those are the individuals who may be at risk for becoming exposed to Ebola. So moving from left to right.
And can I just add one thing? Sure. Ebola, different from COVID, it's not spread in the air. You have to touch somebody to really have that exposure. So that's one of the things that makes it really different. We're talking about people who have had physical contact generally with sick individuals.
Right, direct contact with blood or body fluids, and the funeral part comes, there's some washing of bodies that people are doing, and so you can get exposed to body fluids that way. So in this scenario, this person is tending to an individual who has died, and at that time, people are at their most, they have the highest burden of virus around. So that is a high-risk exposure. So next, the time it takes from exposure to when symptoms start, or the incubation period, is generally about 2 to 21 days. And during that time, you feel fine. And most importantly, the virus, you cannot transmit the virus if you do not have symptoms. So that is totally different from a virus like COVID, where you can transmit when you don't have any symptoms. Ebola does not transmit unless you have symptoms. And so typically when those symptoms start in the next panel, they're really kind of non-specific symptoms. So fever, tiredness, headache, joint pains, muscle aches. And then people will go on to go from that dry phase to something we call a wet phase, when individuals will develop vomiting or diarrhea. Less than half of patients actually develop these bleeding. But then as people go on to get sicker and sicker, it's this loss of fluid that leads to severe illness. And then individuals will go on to, can go on to die soon thereafter. With about a 50% case fatality rate. So of those infected, the number who die can be up to half. So it's a very serious disease that we have to keep in mind.
Perfect. So, Ebola, thankfully rare, but when we start to see an outbreak anywhere in the world, it's a big deal because that case fatality is so high. So first, I wanted to actually just show you some pictures from when I have worked on the outbreak side of Ebola. So here in Chicago, if you think back to 2014 to 2016, that was when the last big Ebola outbreak was. In Chicago and in the US, we were on alert. We were checking folks. We had to rule some patients out, but we did not have a substantial Ebola outbreak here in Chicago or in the United States. But at that time, I was working for the CDC, and so I was able to deploy twice in my role to actually be part of the response on the African side. In that case, the outbreak was in Liberia and Sierra Leone, in that area, and I was in Liberia. But I want to just show you a few slides because the point is the way we think about responding to an outbreak, no matter where it is in the world, is actually pretty similar, even though the resources may be different. So first of all, we want to think about an organized medical and public health response. This is what Christopher Shields' team is all about. How do we make sure that we are sharing information, creating plans, creating structures, having good communication? So this is the Liberian Ministry of Health and Social Welfare, and this was home base. This is the CDC in Liberia. And then lots of teams working together. These are Liberian colleagues, WHO colleagues, CDC colleagues. You can see a lot of the work is actually sitting with papers and with computers, and being very organized about the data is a crucial part. It also takes a huge toll on staff. We've seen that, during COVID, which of course was an outbreak that was very much here and everywhere. But when I was in Liberia, these were the kinds of signs up. There will be no Independence Day break. There will be no weekends. There will be no holidays for the whole county health team staff during this period of emergency. It's an amazing stressor on the public health and the healthcare system. Lots of need to take care of individuals. And it really is all hands on deck when one of these happens. The second thing that we're thinking about is safe patient diagnosis and care. No matter what the outbreak is, no matter where in the world it is, even here in Chicago, we're thinking about how do we make sure we can safely take care of individuals. So the first time I deployed, there were not separate facilities to take care of patients with Ebola. So this is an example of This is one of the doctors and his team literally building an Ebola treatment unit, like outside of the hospital, putting up bricks and putting up tents and just making sure there's a place where you can safely separate individuals. Here in the US, of course, we have more ability to do that in hospital settings, but the basics are the same. And then in my second deployment, there had been a big worldwide response, and they stood up these large Ebola treatment units. Again, temporary, but the need to take care of people and make sure that the healthcare workers have excellent PPE. In the Liberian setting, you're going to reuse a lot of your PPE. You would wash the gloves and wash the gowns and put disinfectant on them. Again, different, but the idea of taking care of healthcare workers is really, really important. Same thing in COVID here. The focus on PPE, taking care of those healthcare workers while they take care of patients is critical. The third thing that we always are doing is how do we stop transmission, right? Sometimes that's a vaccine, if a vaccine is available, but at the heart of it is case finding and contact tracing. So this is the Ebola National Call Center. He's sitting there taking calls of, suspect patients and sending out ambulances and figuring out what hospital they're going to go to. This is the same kind of work that we do here. The coordination, again, of making sure there are not people out there who have the disease who are not diagnosed. And then, there was a lot of door-to-door in some of these small villages. These are some of the Liberian teams I was working with. They literally are going to every single house here, taking everybody's temperature, making sure nobody has Ebola. You'll quarantine the whole village sometimes if there's been a case until you're sure that there's not going to be additional cases because it is so contagious. But it's a lot of on-the-ground work. And then finally, the work of community engagement and education. There is a lot of misinformation whenever an outbreak hits. We saw that here with COVID. This was, again, an example of when I was there. There were newspaper articles where people were debating, did Western Pharmaceuticals, did the U.S. Department of Defense, did they create Ebola? Did they create AIDS? Are these being tested on Africans, right? These sorts of misinformation, there's a lot of mistrust always at the time of an outbreak. There's a lot of work to combat that. And a huge number of people, these are some of the general community health workers later in the outbreak, that there were hundreds and hundreds of Liberians who were working every single day to go out and spread the information, decrease fear, make sure people had the resources they need. And we really saw communities step up in the same way that we saw here in Chicago during COVID. This is a press conference. There was a hospital that had a lot of cases and had to shut down, and you're really making sure that people have the information. On the right, this was a woman who lived in the village where the hospital was. You can see she's bringing in toilet paper. She's bringing in sort of rehydration for patients and for the people in the hospital. Often we see things get difficult, but we often, when I think the community comes together and builds trust, it is also a time for saying, how do we get through this together? And then finally, this is just a picture I love. This is from the end or near the end of the of that outbreak in Liberia. This is one of the doctors in the Ebola treatment unit who is pointing to the fact that they have 20 available beds and 0 patients in them, and that on the right there he's showing those were they would do these hand drawings where people recovered from recovered from Ebola, and they were able to get them out. So Ebola, we work on ending this, and again the outbreak here, tomorrow we are expecting in Uganda this time it to be declared as over. So with that background, I want to pass it over to Christopher Shields, again, who leads our preparedness and response work here in Chicago, to talk about how we do this kind of preparedness and response, even when an outbreak is happening somewhere else in the world. What are we doing on our side?
Can I just say one thing?
Please.
That I want to thank you for grounding this discussion in such this upfront kind of these pictures of what happened, and that really how lucky we are to have a commissioner who really who has been there and done that and understands what's going on in these under-resourced areas and what we have to think about and focus on when we're thinking about them here far away. So I appreciate
that. I think we forget that we have resources in a way that so much of the world may not, and a disease that happens anywhere also affects us. And so the need to, there was a lot of work to get additional resources to Uganda, which is much more prepared than Liberia is anyway at baseline. But yeah, thank you for that. So go ahead, Chris.
Yeah, thank you. I'm using this slide as a good representation or an example of the things that traditionally happen within the city of Chicago. So when we're thinking about disease outbreaks and we're thinking about the collateral impacts associated to weather events, associated to large assemblies of populations, this is just a good place to show that the city of Chicago is a very large city, 2.75 million people. But the number of visitors that come into the city is extremely large. 35 million travelers come to the city of Chicago, coming to our special events, coming to use our city as a place of knowledge and learning, for recreation, to share in the Chicago experience. With that, also 2 international travel points with our airports.
So some of the large-scale events that we look at across the city, if you're not familiar, the City of Chicago hosts about 2,000 special events a year. This is just a smattering of some of our larger events. So events of magnitude and scale. Obviously, with the Chicago Cubs winning the World Series. I think that was 2 days of very exciting activity throughout the city. Lots of population in a small area. We look at some of our large special events, the Pride Series, our Lollapalooza events. Again, large populations within a small area of the city. And for the last 3 years, while the conversation today is going to be speaking specifically around the Ebola response, there have been 5 concurrent disease and large-scale responses that the city has been involved in. So not only is the team focusing on the now, but we're also focusing on what's happening parallel to it, and then looking into the future of what potentially could be coming our way next.
And every time we have these events, we use them to sort of exercise plans to think about, say there is an infectious disease outbreak, say there is an issue. How do we take advantage behind the scenes of these really fun events to make sure we are as prepared as we can be?
Absolutely, and let's tie on to that. Part of the preparedness planning cycle is to not only look internally within the city resources or the health department's resources, but to look externally, to look at what is the state's level of preparedness, what is the United States level of preparedness. So the next slide, I'm not going to spend very much time on it, we actually look worldwide. And this slide is specifically about terrorism, and we use this as a base model of what's happening in the world. Because there could be an event that's not disease specific that could cause a migration of population to come to the United States. And with that population, the potentiality of endemic disease moving with that population as they rotate to the United States. So we're looking at what is the world doing. And my team spends a lot of time on this kind of forecasting outward. This next slide is a good representation of all the disease outbreaks that are currently going on worldwide. And so we have a component in our division that's doing surveillance. They're looking out into the world to see where are there disease outbreaks? What is the disease? What is the probability that this disease could move from the country of origin into the United States and then into the United States to the city of Chicago? So we're looking at lots of platforms that give us predictive analytics or the thought process of how a disease moves. And then we're also using that information to inform decisions on what is the city of Chicago as part of preparedness planning, what are we going to keep in inventory, what type of materials, what type of technology, what type of computer systems, what do we need to have here so that should an event occur, we can be immediately operational and move forward. I'm going to turn it over to Dr. Black for the next couple of slides.
Okay. So in terms of Ebola virus outbreaks, there have been many since 1976, 33 outbreaks due to Ebola virus. And that has been the Zaire Ebola virus, which is a little bit different from Sudan virus, which is the cause of this now concluding outbreak in Uganda. And the concern with Sudan virus is that there is not an approved vaccine for this virus at this time, or experimental therapies. So while the vast majority of cases have been Zaire, again, in the past, that is a disease from which we have mostly learned. So most of our knowledge of Ebola virus comes from outbreaks caused by Zaire. I want to show you, though, that Sudan virus, there have been 7 now outbreaks that have been in Sudan or Uganda. And Uganda is very experienced in dealing with these outbreaks. And as you can see, the outbreak in 2000, there were 425 cases. And subsequent to that, there were much smaller outbreaks. Now, the current outbreak has a higher case count of 164 at this time, but that was because the beginning of the outbreak, there was transmission happening in the community and the transmission was not immediately recognized. But Uganda is well experienced and has been able to get the outbreak under control. And so on this next slide is the current situation. And I should say that the Ministry of Health in Uganda has been putting out periodic reports. And it's so critical to get information out to people so that the world really has situational awareness of what's going on. And so this map is actually from a report that's generated by the Ministry of Health in Uganda. And you can see yourself, if you look at these links, what those reports look like. But the total number of cases is 164 individuals. And there has now not been a new case for just about 2 incubation periods. That's 42 days, which is the reason that we are hoping that as of tomorrow, that the Uganda Ministry of Health will declare that this outbreak is over, and then subsequently the WHO and CDC. So we're looking for that to happen hopefully tomorrow. There have been 77 deaths, resulting then in a case fatality rate, so the number of individuals who have died of those infected, of just under 50%. There have been 9 districts in Uganda that have been affected, and the names of these districts have been very important to those individuals who are monitoring travelers. Each and every interview that happens by our team, we ask people if they have been in these districts and what they were doing when they were there. Important to keep in mind, too, that among the cases, there have been 19 individuals who were healthcare workers, and of those, 7 who have died. So again, back to some of the material Dr. Arwady was mentioning around the importance of PPE and training, and why we take it so seriously to protect our healthcare workers, too, as we consider illness in individuals who have traveled. So in terms of controlling an Ebola virus outbreak, Dr. Arwady did cover some of these topics. So very important to identify new cases, and that involves individuals who may just have an EpiLink, so they've had an exposure, like the exposures I talked about. Laboratory testing is a key part of that, and even doing a sort of advanced laboratory diagnostics to understand better how the disease is spreading. Critically important to monitor contacts. That's done for a period of 21 days. So that incubation period, the time when someone's exposed to when they develop symptoms, that has to happen. That is happening in country, or was happening. That has now concluded. Educating healthcare workers, the healthcare community, and the community at large. It can't be stressed enough how important it is, that people follow safe burial practices. And also this issue of trust is so critical, especially you can imagine when deploying experimental vaccines, that the community, it's so critical to have people understand the objectives of trying to control the outbreak. And then lastly, I just want to mention that security is an issue in these outbreaks. In West Africa, that was a big deal in the DRC, in terms of, healthcare workers the community being able to focus on controlling the outbreak rather than having their attention deflected by, of course, life and death issues around security.
So when we talk about planning, and the slide says local planning, planning transcends not just the health department, but across the super system as a whole. So all city agencies are involved, all of our external planning partners, from the healthcare enterprise to our emergency management side and to our federal partners. And this slide kind of highlights the fact that there are multiple steps in a process, but they're all interlinked as we're going through an investigative cycle. So our screening started through O'Hare and our international terminal, and we've had just over 2,100 clients come through from Uganda that then became part of our screening and monitoring profile. Then we're looking at the preparedness messaging. So we're messaging, these are the types of things we're looking for. What are you looking for in the community, without raising a level of scare? So the systems are in place, but we need to inform the community on what's going on, so that helps everyone understand where we are in the healthcare setting, where we are as the health department, and what we're moving forward. Then our coordination across the healthcare system is integral. So what hospital information do they have? Do they have the appropriate PPE? Have they gone through the training cycle? Do they understand presentation of a client? Are they in communication with our epi and surveillance and our communicable and infectious disease divisions on, we potentially have a client, we're going to ask you to manage this client's health care? And then the intergovernmental relationship, I think, is key. So there are partners in this response that aren't City of Chicago employees. We have our Division of Global Migration and Quarantine operating out at O'Hare Field. We have our private sector hospital systems that are participating not only in the weekly meetings, but in the how are we going to manage case management. Then we have the internal team that's doing the monitoring of case evaluation and then sharing that with our state partners. Because just because a client came to the City of Chicago didn't mean that was going to be the final destination. And as Dr. Black and Dr. Arwady had identified, you cannot pass the disease unless you are symptomatic. So clients, the best place for you to go into your monitoring cycle is to get you to your final destination in the safest mechanism possible and then turn it over for the monitoring through the sequence of your infection period or your period.
Okay, and this next slide is sort of a graphic depiction of what Chris just reviewed. But to get just a little bit more into the work that our teams have been doing at CDPH. So we have the travelers arrive, they are screened at the airport by staff there.
Every traveler from Uganda.
Every traveler, sorry,
outbreak.
yes. So travelers from Uganda. So, and our team contacts reaches out to each of those individuals and enrolls them in monitoring, which happens over a 21-day period. And depending on if they were in an outbreak area or they were not in an outbreak area, those districts I was mentioning in Uganda, those are the touch points that they will have. And they are given a phone number which they can call if they develop symptoms. So there's kind of a warm welcome, like welcome back. We are the reason that we are monitoring, the signs and symptoms to look for, and then a phone number to call if people develop symptoms. And that phone number is checked on the weekends. That's something that is done each and every day. And so if an individual does develop symptoms, there are doctors on call. Also, our medical directors have been following so that if an individual does develop symptoms, that consideration can be given to whether they should be tested for Ebola virus. And there's a lot of communication that happens there. If there's going to be transport, we are working with our EMS. Our laboratory team works with the Illinois Department of Public Health. We are able to test locally for Ebola virus disease thanks to their work. And there needs to be a high level of suspicion, a significant level of suspicion to be testing. We do not test each and every person, as it is much more likely that individuals have malaria than Ebola virus disease. And then we also coordinate the appropriate place for an individual to be evaluated. Be that a special pathogen center that has been specifically trained and agreed and has to care for patients with Ebola, or any emergency room, because sometimes individuals may potentially present without calling the health department first. And I will mention that these palm cards in the upper right corner are given out to people at the airport so they know what symptoms to look for. And our team reviews those symptoms when we make that initial contact with them. And so getting to the healthcare system, so we have messaged to broadly to our hospitals and healthcare systems that individuals on screening, anybody needs to be asked about their travel history. So where have they been? Have they traveled to Uganda? And then identify what their signs and symptoms are. And if they are of concern, there needs to be both an exposure history and the appropriate signs and symptoms that they're put in the appropriate isolation, so away from other people. and then letting the health department know what's going on so that we can help with additional diagnostics, as I mentioned, and where individuals are cared for. And speaking of that, we have a picture of our 3 special pathogens treatment centers. So Rush University Medical Center, Northwestern Memorial Hospital, and the Ann and Robert Lurie Children's Hospital have all trained extensively. They have areas in the hospital that are able to be cleared and designated to care for patients with Ebola, and really expert staff who are ready to be here for individuals who develop illness for which we might consider Ebola.
And I think the last piece, and this is systems and infrastructure. So again, the conversation is about Ebola, but a lot of these systems were put in place for diseases from a long time ago. And we've built up our capability here within the city of Chicago by investing in the technology, investing in the infrastructure, the supply inventory to ensure that our hospitals can stay online during emergencies, and in this particular case, for a highly dynamic but not localized emergent response. So lots of systems, lots of technology, our ability to regulate our storage environments so that we can extend the life. We talked about extending the shelf life extension of the COVID tests. Very similar happens to a lot of the inventory that we have for the health department and the city as a whole. Expanding our vaccine management platform to allow for movement of vaccine in all variable temperature ranges. The lab sample capability to move lab samples for testing to ensure that we have the integrity of the product to be sampled so that there is no loss of time in coming up with a differential diagnosis. And then at the end, being able to track all those resources as they're deployed out into the world and then returned back to be either put back into storage or to be cycled into the next response. And again, we have 5 concurrent responses, and optimistically it'll be 4 as of tomorrow. But a lot of those same infrastructure pieces are used regardless of the disease response, with alternations based on the level of care that we would be providing for clients. And I'll turn it back to Dr. Arley.
All right. So that was a lot of content. We can come out of the slideshow. But I want to thank both of you for going through that detail. The reason that we decided to focus on this today is we get a lot of questions from you all about, what are you doing to be prepared? That a lot of you probably only thought about public health for the very first time because of COVID. But this is what the health department, not just here, but around the country, this is what health departments do. We get ahead as much as we can of a disease situation, and then we work to make sure we are coordinated, we are communicating well, that we have safe places to take care of individuals working with a health care system, and then on the public health side, that we're doing everything we can to contain that disease. So we'll go ahead and start in on your questions, but while I'm transitioning over, when you think about sort of the difference between this Ebola response and the COVID response in each of your areas, what do you think some of the things are that really stand out to you as major differences?
I think for me, is the Ebola response was specific to a group, to a location. You had to be in a specific location. You had to do a number of things that would result in you falling into a category that required monitoring. COVID was universal. It went worldwide. And while we talked about the early days of COVID and the first case and the first human-to-human transmission case, that was a small piece, but it was evolving rapidly. And all the systems that we had put in place, we had people doing predictions. How far is this going to be? While we're looking at control and contain, we're also looking at, okay, if this moves, what are we going to have to do next? And walk through a thing, if you've come up through the military, courses of action and decision trees that the critical thinkers across the city needed to make long before they were presented with the question, setting in motion what was going to need to happen.
Yeah, and I would say that if this is, preparing for a small number of individuals that is with a very high stakes disease. So it's not like Ebola would come over here and spread wildly, because people have symptoms that would be that would bring them to medical attention. But critically important to have engaged healthcare team, both at the health department, at EMS, being ready to support that team, and at the healthcare centers, taking it seriously and being ready. And I do also want to highlight our infection control team, who stands ready even all through COVID, working with facilities about how to mitigate spread of COVID, but is available too for how to best assess patients at the time, and regardless of the setting, whether it's a clinic or a frontline hospital, so any emergency room, or the special pathogens treatment centers.
All right, great. So we've got a few, I was just looking at sort of the chat while we came off here. So we've got a number of questions sort of about preparedness at Ebola. We've got a number of questions, and I see this really robust conversation happening about masks online, so that's great. Number of questions about sort of COVID and XBB variants. So we'll sort of do the rounds and hit on those. So first of all, let's actually start with one of the kind of Ebola and preparedness questions. So first, Amelia Marie on Facebook says, thanks for all you have done, during the pandemic and with this guidance and information is excellent. Thank you, Amelia. And then a question, if Uganda and WHO and whoever declare the outbreak over, does CDPH stop monitoring? What happens then?
The answer to that, basically in a word, is yes.
Right.
Monitoring will stop at that time.
Yep. Okay, good. Let's hit a couple of the COVID ones, and then we'll come back, and you both of you feel free to chime in on any of these. So some questions about the XBB 1.5 subvariant. So Barbara Rivers from Facebook says, when do you expect to see the new variant? So we have seen it. About 7% of our cases in this last week here in Chicago, across the Midwest, were this new subvariant. That's different than in New York, where it's about 70%. I do anticipate that number for the new subvariant will go up each week, but it is already here, which is why it's important that you're up to date with vaccine. And then DS Shin on Facebook is asking, are the at-home tests still effective with this new XBB 1.5 Kraken variant? Are we expecting a surge since we usually follow New York? Do you want to, just to mix it up, do you want to take that? Are the home tests still effective?
Yes, FDA regularly follows the tests to make sure that that the tests are still effective, and these are still Omicron derivative variants.
Right. So that's right. So every single time there is a new subvariant, every single time they are checking all the vaccines against that variant. They are checking the tests, making sure that we are not seeing the emergence of a variant where the vaccine isn't working, where the tests aren't working. So the good news is vaccines, tests, and importantly Paxlovid, the treatment, are all still working against this subvariant. And so to the question about are we expecting a surge, since we often follow New York, I'm expecting to see some increase in cases. New York is not getting overwhelmed with hospitalizations, which is great. They are up, not surprisingly, because cases are up. But again, we have tools. We have vaccines. We have treatments that can help keep this hopefully under control. So it wouldn't surprise me to see an increase in cases. It also wouldn't surprise me if we move from that medium to that high level. I would love it if we didn't get there. But I am not anticipating, based on this subvariant, the major surge where you're talking mass mandates or, like when Omicron first got here. And so to Kriskin Korkowski on Facebook's question, how is this new subvariant affecting Chicago? I think at this point it's just another subvariant, and the thing worries me the most, as always, is people who aren't up to date with their vaccine. We want people to be up to date, and then other than that, it's just another version of COVID at this point. Okay, so let me go back up to sort of some of the conversation. Here's a good one. So somebody says, good to hear about this Ebola outbreak being over, but not to get off topic, what would it take for the COVID pandemic to be declared over? I love that question. Do you want to start with that one?
So the last person is 2 incubation periods past.
Right.
Yeah. We need more people vaccinated.
Yes.
With the booster vaccine, and I think we are expecting that there will at least be annual vaccinations for COVID because it's biology, and the virus will continue to seek to mutate as long as it has an opportunity to cause infection, which just all comes back around to vaccination.
Yeah. Do you want to add anything on that?
Yeah, so the conclusion of the COVID pandemic, I align it with the never-ending cycle of the influenza
That's right,
development. So viruses go through a mutative cycle, and the things that you learned in kindergarten are the most effective things for, aside from vaccination, washing your hands, covering your cough,
Staying home
when you're sick, and then for the mask side of the house, when you're out in the public, and we used to not see people wearing masks, and I think COVID has brought to the American consciousness that lots of places across the world wear masks associated to endemic respiratory disease. So we didn't see a lot of influenza cases when COVID was dominant. Now we're starting to see them level out. But the protective measures are the same for both of those diseases.
That's right. And, I agree. We're not going to see over in terms of COVID disappearing unless there is some just huge breakthrough. I don't think that's going to happen. It's going to be like influenza. Like I agree entirely. We think of the flu season. Every winter, there's a flu season. That is really a respiratory virus season. We still don't know for sure that COVID is going to follow that same pattern of it being a winter thing, that it's worse, because we've certainly seen surges outside of when it's cold. So there's still some questions. But the difference, let me highlight, Ebola cannot be transmitted before you have symptoms. That's the biggest difference of the whole thing. When people are able to transmit a disease and they don't even know they have the disease, it puts it in a whole different ballgame. It makes it so much harder to do effective contact tracing and containment. And that is the biggest difference. And then the fact that it's spread, via droplets and via air also makes it entirely different. So, I think it's moving. It's still in that pandemic phase where it is affecting the whole world. It's one of the top 3 causes of death. Over time, hopefully, it will dwindle. It's already really different than it was in 2020, thankfully. But I don't think it's going to be over and gone in the same kind of way. Okay, Amanda DW on Facebook says, thanks for all you do. So interesting to hear all that goes on. I finally tested negative on a COVID rapid on day 14 today, but my cough is still pretty bad. Is that contagious? Great question, Amanda. So if it's been 14 days and you have a negative test, I would not anticipate that being contagious. The cough is going to be almost always, when you have any kind of viral illness, it's going to be the last symptom to go away. So there are a lot of viruses going around right now besides COVID. There's COVID, there's influenza, but there's all, RSV and all the regular flus. And typically you'll get over that acute phase where you're having fever or runny nose, or and then the cough can extend. We call it a post-viral cough, for weeks sometimes. But no, you are very unlikely to still be contagious. That said, if you're still coughing a lot, it's probably not the time to go visit your 98-year-old grandmother, right? So a little common sense, but you are unlikely to be contagious. I would keep the mask on just from if you're out and about. People understandably get nervous where they hear someone coughing a lot right next to them, but you are unlikely to be spreading significant germs. Anything? Yeah.
No, agree.
All right. Alexandria DN on Facebook is asking, are you seeing a rise in ear infections for children with all of the respiratory viruses going around? I'm hearing a lot of kids with ear infections lately. I have thoughts on that, but do you want to, as our infectious disease doc, do you want to say anything there and then I'll chime in?
I mean, it's a potpourri of respiratory viral infections. I mean, fortunately, we're seeing RSV come down a bit. Flu has kind of been trending down. But yeah, it's not surprising that that you would see pediatric ear infections.
Yeah, and I would just add to that during COVID, it was a very strange time for outpatient pediatricians because a lot of the regular childhood illnesses were not showing up very much. So it's not so much that ear infections are really, really high right now. It's that they've rebounded after having been low during COVID. We were just not seeing a lot of the other respiratory viruses in the same way. COVID probably had some competitive advantage, plus, especially during the time where we're isolating and, all of that helped keep these other viruses down. And so with the resurgence of other viruses, I don't want to get too much into the details of ear infections because that can be caused by different things, but it is true that if you're having viruses and kids are getting congestion, et cetera, you can have some increase in ear infections. So yes, there is more of that. There is more of everything right now because we're seeing a few years of these other viruses all emerging at once.
Yeah, I was just going to say the shifting of the period of spread has really been a challenge,
Yes.
I think, for clinicians. And so that's why surveillance, like keeping track of what we're seeing in the lab, is so important so we can try to inform people of what's going on.
And making really sure that kids are up to date with all of their routine vaccinations, right? We saw different patterns of people seeking health care. We've seen some drop off, and that can also contribute. Chickenpox, for example, right? We vaccinate against that now, but where people haven't maybe had that vaccine, not so much here, but in some other places in the US, they're starting to see some more significant problems with that. So, but yes, there is a lot around right now. We've got just a few minutes left here. Jose Alejandro Garcia from Facebook says, do you guys have a number for healthcare insurance for those who are less fortunate? So first of all, thank you for that. Generally, people are able to get health insurance if they are in this country, if they are either citizens of this country or they have documentation if they're asylum seekers, et cetera. You're able to get insurance, but in this country, you do have to apply for that. And that is a barrier, and it's different than in a lot of other countries. And so I just want to remind everybody high level that for folks with income levels below a certain point, you can get Medicaid or the pieces that come with that. For everybody who is older or certain disabilities, you can also get Medicare. Those are both governmental health insurance programs that take care of folks who are the most vulnerable. In addition, there's colloquially it was called Obamacare, when the expansion of private insurance came in, so that for many people, you might not know, you can sign up for health insurance, and if you're below a certain threshold, you might pay $0 or you might pay very few dollars for actual private health insurance. So our health insurance situation is a little complicated in this country, but we definitely want to get people connected. So, one thing I would say, you can always call any of our regular hotlines and we can get you connected. If you call 312-746-4835, that's our COVID hotline, but the folks there can help you get connected to a navigator. We also have, there's websites, there is information online, and we can bring some more of that back next week if you want to see some details. But if you talk to, all of our federally qualified health centers here in Chicago, we have 21 different systems. So that's your Erie, your Access, your Esperanzas of the world. All of them receive government federal funding to take care of anybody, even people who are uninsured. So if there are people who are in the U.S. but may not be fully documented from an immigration status, maybe they can't qualify for insurance, or people who haven't yet been able to get their Medicaid done, your federally qualified health center will take care of you and will also help to get you connected to that care. And so there is more information on our website, but I would encourage you, going to the neighborhood clinic, having a conversation, giving us a call, really at any of the numbers, and we can help get you connected. Okay. Barbara Stephen on Facebook is wondering, in the future, will we see combined COVID-19 and influenza vaccines? What do you think?
I think that would be great. And I do think that that there is work going on to look at that. I think that right now, though, the COVID vaccine situation is still being kind of sorted out in terms of, which is the right, it's clear that they will need to keep updating. So picking the right flu strains, which is done now, in advance through what's circulating in the southern hemisphere with what's happening with COVID, I think that's complicated, but it's a great idea.
Yeah, and I think there's a good chance if this. My expectation, kind of like we make a flu vaccine every year that comes out around August or September to then cover you through the winter. My guess is that we'll be doing the same thing for COVID. And if that is something that happens where you're updating it based on the variants and the subvariants, I do think that there's a good chance that they'll work on combining these. But we're not there just yet. And
the message being that you can get the COVID and flu vaccines at the same time. Now.
Yep. Okay, so let me just take a few of these masks ones real quick. So first of all, Dabo Hill from Facebook says, many are still not vaccinated. Some, I think this is a typo, but she's saying there are people with RSV and flu in the hospital. She says, yet y'all don't have on masks. What should we believe? So let me emphasize, first of all, we are at a medium COVID level. We are at a medium COVID level, which means we recommend putting a mask on, but we do not even have at this point, an advisory for masking in all indoor settings. I do put masks on, but when we do Facebook, and we've done this from the very beginning, we don't wear masks in this setting. We all do not have symptoms. At times, trust me, we are all testing if we have exposures and doing what is needed. Also early on, before we are also entirely all up to date with our vaccination. And if you recall, early in Facebook, we would always do this thing to make sure we were keeping that 6-foot distance. So we all, I can tell you this right now, I popped my mask on and off. We all had masks on when we walked into this room. We also put them on when we have masks. We are all sort of on the more conservative side of mask wearing because of the work that we do. But if you are not vaccinated, because you start out here saying many are still not vaccinated, I am worried about you, and I sure hope you're wearing a mask, and I hope you come up to date with your vaccine. So thanks on that. And then Jesse Aikens on Facebook is saying, should we wear masks inside public buildings? What about churches? So here too, at the medium COVID level, we are encouraging it, right? Numbers are up, especially if there are people who are not entirely up to date with their vaccines, or there are people who are at high risk. And I think in churches, we've had lots of conversations, not just with churches, but with various religious leaders. We are not at a point, again, if we get to a high COVID level, we'll be making that formal mask advisory to be putting masks on. In the meantime, if you are getting together with a lot of people with underlying illness, masks can be part of being welcoming to all within that setting. But we also know that churches and other settings are back to having, the coffee and the cookie hour, having those important pieces. We want those to be part of being back to life. COVID does not have to be the first thing top of mind. So while we are not at a high level, no, I do not have a recommendation that says everybody must have a mask on all the time, but know that on an individual basis. And if you are worried yourself about COVID, you are higher risk, you are not up to date with your vaccine, whatever it is, you putting a mask on, especially one of the KN95 masks that fits and has good protection, can help protect you as well. So either of you want to chime in anything else on that?
I think the importance of a well-fitted mask. Don't wear it on your chin. Don't,
That's
let
right.
it slip below your nose. It's very important to wear the mask correctly. And, if you have an immunocompromising condition, you should be, when you go to the grocery store, when you're at a place on public transportation, you should definitely mask up.
Yeah, and Jesse Aikens, I see your comment. People are coughing inside the store. I'm going to keep my mask on. People don't cover their mouth. Absolutely. I always have a mask in my pocket. And let me tell you, I see somebody, I wear it a fair bit anyway, but if I see somebody coughing, think of it like an umbrella. Maybe you don't have it on all the time, but there are times you want it and you need it, and pop it on. And I see Claudia Hicks is saying use common sense. If you're indoors, protect yourself and wear a mask. Barbara Stevens says, I play it safe, wear a mask anywhere you don't know the people surrounding you. And I think thinking of it as just another tool, right? It is an important tool. And I appreciate everybody's thoughts around that. So we're just going to go another 5 minutes or so. George Heyman on Facebook says, thank you, Allison and team. Chris, are you preparing for a zombie apocalypse?
I find that entertaining because that was one of the early scenarios in 2002, 2003. What would the world look like if we were dealing with a zombie apocalypse?
Not in a real way, but in a fun preparedness kind of way.
Correct. I think one of the pieces, and I would say yes, not that I'm worried about dead bodies being able to move around, but all the things that would be involved to bring us to the state that would be real. That you would have loss of supply chain, you would have loss of governmental control, loss of healthcare enterprise, probably civil unrest, loss of food, all these things in that post-apocalyptic world kind of thing. Some of our plans do have a basis in that. While it's not zombie, you're looking at all the things that would disrupt a cycle. Going into the COVID response, the city had just come out of a national exercise series where we looked at all these potential threats that could occur and when would they occur in the sequence and what would we do to address those threats. All of them came true. So to take your point, we were looking at worst case scenarios, thinking that we would never see all 15 planning assumptions come true during a real world event, and yet they did.
Yeah. All hazards planning, we call it. So zombies not high on the list of probable, but we plan for all hazards.
It's a good idea to establish your medical home, I think, too. Like, know where, or get vaccinated and know where you can reach out for help. I'm just reminded of this because every time I go to get my haircut, my hair stylist is always like, is this the one? Is this the zombie apocalypse? It comes up every time because he knows what I do.
All right. So I see Christy Van Ryan from Facebook's comment on here. She wants to hear more about, she says, Dr. Hardy, please discuss CDC VAERS data. VAERS data is the Vaccine Adverse Event Reporting System. She's saying it's showing, there are vaccine adverse events, there are deaths, talk about myocarditis, blood clots, cardiac arrest. She says, you push these shots, you say they're safe and effective. The fact is they are not. So I don't have the time right now to go through all of the detail on VAERS, but how about the next time we talk in some detail? Because I've talked about this a whole lot. I want to underscore these vaccines have been given not 12 million times, 12 billion with a B times. We have never had the amount of monitoring, safety checking, studying, both before the vaccine is released and after the vaccine is released. And I am absolutely confident that this vaccine is safe and this vaccine is effective. It's why I get my vaccines. It's why, my nieces and nephews get their vaccines. It's why we spend huge amounts of resources helping people understand. VAERS is a system, and Steph, maybe I'll let you just quickly chime in and we'll talk more next week. But it's a system where anytime anything happens after anybody in the world has a vaccine, you are supposed to report it. So if somebody gets, say somebody has had, I'm trying to think of an example. Like, in theory, you get hit by a car and you got vaccinated yesterday. Like, you could enter that in terms of something has happened. Is the chance that you got hit by a car affected by your vaccine? No, it is not. And yet it'll be entered. There was a little bit of conversation about the football player who had the cardiac arrest after getting hit on the field. And I want to emphasize that, if that person had a COVID vaccine in the past, that COVID vaccine is not what is linking to that person's cardiac arrest. It is happening, years sometimes after somebody has had a COVID vaccine. But there is a tendency for people to, want to link some of these. And so VAERS is one of the systems where we use to look at anything that could be linked. It's an important system. It's where you look at signal. If you see a signal around myocarditis, around blood clots, around heart attacks, you do the studies, you do the investigations to see if there is something there. And I think, I've talked about this really openly, that myocarditis is that inflammation of the heart muscle. This the type of myocarditis that people recover from right when for the teenagers, the boys, there was an increase. We were seeing a little bit of a signal for some increased risk of myocarditis around vaccine. To be clear, though, that increased risk of myocarditis around vaccine was tiny compared to the risk of myocarditis after getting COVID-19, including in teenage boys. And so you're always thinking about, how do I protect against sort of those risks? And so they looked at that. There were studies, and they were used to change and adapt a little bit the dose that children in particular get around COVID vaccines. And so we've not seen signals. I shared, if you follow us every week, we've shared the safety data. We have not seen signals around myocarditis or anything else in the vaccines for kids sort of after that point. So we can talk some more about VAERS, but I would encourage you, please talk to someone, talk to your doctor about this, okay? There's lots of stuff out there online. I can tell you're doing reading, which is good, but please talk to your healthcare provider who can look at your health history, who has this background, and can help share in a way that hopefully makes sense for you why this vaccine is safe, effective, and recommended. But I have absolutely no hesitation in saying that myself. So we'll talk a little bit about VAERS, though, the next time if you want to come back. All right, so we are at time, and there's a few we didn't get to, so we'll pick some of those up. But there's a comment here from Carly just saying thanks to you for sharing information on the Ebola outbreak. I remember hearing about it briefly when the outbreak started. Being able to contain the outbreak as best you did, and for you, I would say internationally, seems like a public health win. What are some other examples of public health wins that might not be in the news in the same way that COVID has been? So we have public health wins every day. Every single day, there are things that happen behind the scenes that never make the news. People go into public health, actually, often because we like the collaborative work of preventing disease. Like, when nothing bad happens, it doesn't mean we weren't working on it, both of our teams. And success for us, success from a preparedness standpoint, means you don't have a problem, right? You don't have an issue. And often that isn't, that's not the way humans tend to think. And so, thank you for the comments. Thanks for those of you who joined in. The opportunity, I think, to just talk a little bit about that behind the scenes work. This is your city government working for you, really, at the end of the day. And we care a lot. We have hundreds of people on these folks' teams who spend every single day protecting Chicago, against diseases and against any other health threat. So with that, thank you again. This is Dr. Stephanie Black. She's one of our medical directors for infectious diseases. And then Mr. Christopher Shields leads our emergency preparedness and response work. So thank you both to you and your teams. Any just last minute thing you want to say, and then we'll wrap it up.
Thanks for having us, and thanks to our teams.
Yeah.
At the end of the day, it's not a single person's effort.
Right.
It's a community of effort. While we're paid to do the effort, your involvement in preparedness planning and control of disease is just, if not more, important than the work that we're doing. So thank you for being part of our team. And again, thanks to the team that works under me for not necessarily getting the accolades for the long hours of work that you do to forestall any bad events that happen in the city.
All right, very good. We will be back at our regular time next Tuesday at 11. Again, we keep track if there's questions we didn't get to. We'll talk a little bit more about VAERS too, just so you have some understanding about that. And thank you for tuning in. We will see you January 17th. In the meantime, please do be healthy. Keep sending your questions in. Thanks again.